Okay, good afternoon, students. Welcome back to the topic transplantation immunology or transplantation biology. We have discussed in lecture 11 yesterday, little bit brief fundamentals of it, how vascularization happens, how a tissue can be accepted or rejected. And also we looked at the fundamental level, how two different tissue types can recognize the foreignness with each other. Basically, we look in terms of the grafts. What is an allograft? So basically, an allograft is coming from this between two species of the same species, two individuals. That is an allograft that we looked in a little bit isograft and xenograft also in the last class. Today's class, I will talk a little bit more on in terms of transplant rejection, in terms of the graft and host, graft versus host reaction or GVHD disease. And also, we will also cover in terms of the what kind of rejection processes can happen given a transplant, what are the types, and what is the mechanism fundamentally, how the graft immune system is going to kill the host, or the host immune system is going to kill the graft, what kind of immune cells they use, immune mechanism in terms of cell mediated or antibody mediated or complement system, or they have something new, whatever we haven't discussed so far. So we will look more in details in terms of these two types of transplant mechanism, and then types of them, and how in terms of the mechanistic level, how the process happens. Okay, coming back to our fundamental slide, donor comes, the graft comes from the donor, the host, it receives the graft, process of transplantation, the transplant will come up. And we looked in two types of the transplant system, where in terms of the graft is weaker. For example, the host immune system is stronger and the host immune cells is going to kill the graft. This is called transplant rejection. Per se, what are these blue dots in terms of the immune cells? You have to think in terms of the mechanism. Are they involving only T lymphocytes, or they involve B lymphocytes? What type of immune cells they involve in terms of, they talk in terms of the macrophages, or they bring the dendritic cells. We have to look in them the mechanism, not the simple blue dots going and killing the graft here. There is a perfect immune response will be elicited. We will see that, what is that. And we looked into another condition where the graft dominates over the host and then it kills the host. This is called as a graft versus host reaction, graft versus disease. Again, when you look in terms of the dots crossing here, in terms of the graft, what are these cells coming from the graft? Whether they are hematopoietic stem cells during the transplantation, or they may be bone marrow cells, for example, or they may be certain peripheral blood cells that may also come. So coming on to the host, the graft will probably bring less repertoire of cells given the host or tissue involved, because you're not grafting the whole immune system per se into the host, but the host will already have the whole immune system, peripheral lymphoid organs, all the tissues and cells the host constitute. The graft will be a small portion that entering the foreign territory here. So the graft cells will be limited per se compared to the host. And while they are fighting each other, the host can elicit varied types of immune responses, but the graft will have a limited responses given the tissue, living tissue that is grafted and what kind of cells it's been there. So we will look into that again. So one more fundamentally, we have to look a little bit more in terms of talking in terms of transplant rejection. We need to look fundamentally one more concept that is called as alloimmunity. Alloimmunity, or sometimes it's called isoimmunity, is an immune response to non-self antigens, foreign non-self antigens from members of the same species. For example, a human getting a kidney transplant, he will have a non-self antigens coming from the other human, but basically the antigens belonging to the human family, nothing but HLA haplotypes or polymorphism. So alloimmunity is an immune response to non-self antigens from members of the same species. These antigens are called non-self antigens. They are already sometimes called alloantigens or isoantigens. And what are the basic types of alloantigens we have witnessed so far? We have seen that during blood transfusion, the blood groups can bring specific antigens on the type of the blood group, type of the blood cells. These antigens are nothing but alloantigens. On the other type, these graft or foreign molecules can bring other antigens called histocompatibility antigens. MHC molecules coming from the foreign, also non-self antigens, is a type of non-self antigens. A response elicited to these non-self antigens is called alloimmune response or alloimmunity. Basically, in transplant rejection, in the graft rejection, there are many pathways involved, but one concept of the alloimmunity specifically coming on to alloantigens, the body can create specific antibodies specific to these antigens called as alloantibodies. When the alloantigens are recognized by alloantibodies, the body can go in terms of the classical antigen antibody pathway, elicit a complement process, and do a response that is needed. In alloimmunity, the body creates antibodies called alloantibodies against the alloantigen, attacking the transfused blood, allotransplanted tissue, and even the fetus in some cases. It is very important that if during pregnancy, the mother and the fetal blood types in terms of HLA types are different during development. Sometimes it's also very different. The fetus will be treated as a foreign a non-self organism, non-self antigen from the fetus. The mother immune system will try to kill the fetus also in some cases. So alloantibodies helps in attacking transfused blood, allotransplanted tissue, and even fetus in some cases. And alloimmune response is also one of the response that helps in graft rejection. Remember that alloantibodies rejecting a graft, recognizing the alloantigens, is only one type of graft rejection. There are so many mechanisms we will see. So it's alloantibodies and alloimmunity. Coming on to alloimmunity and autoimmunity, what is the difference? You see that allo here, auto here. Autoimmunity means sometimes your body will not able to detect your own as self antigens. They will detect them as foreign, as alloantigens. They will respond, elicit an immune response that is called autoimmunity. Some of the diseases called autoimmune diseases, they will cause autoimmunity and basically kill the species themselves. And alloimmunity is coming from alloantigens from a different species. Of the same species, different member of the same species. Okay, this is fundamentally, you need to remember what are alloantigens, alloantibodies, because it's fundamental in terms of graft rejection also. So now we go a little bit more into the types of transplant rejection. We have seen in the last class that kind of diagram I discussed. If given an autograft, given allograft, how they will go into a foreign tissue, how they will establish themselves. We talked about 12 to 14 days. During that, the first 3 days, vascularization happens. Next few days, there is the establishment of normal immune cells propagation, no problem with the recognition. They recognize the tissue as self, and later complete establishment of tissue and then platelets and blood flow. That is a normal case. But there are many reactions will happen when the transplant is rejected. We looked in the timeline, 3 to 10 days, it can be rejected. Based on the type of rejection, the response, the graft is rejected. It's been divided into 3 types. One is called hyperacute, another is called acute, another one is called chronic. We will see into that what is hyperacute, acute, and chronic. We will look into what are the types of graft rejection per se. And also we looked in terms of a graph where we shown that given the timeline of 0 to 24 months, given the type of haploids, HLA types, we have seen that the cumulative graft survival can sometimes up to 12 months only, but sometimes it can be in 24 months. Everything is going normal. But given the types of the responses here, hyperacute, acute, and chronic, you look into the same graph, you won't be looking at the timeline of months. It's not acting in months. Per se chronic, it may happen in delayed response, but given the time of hyperacute and acute, hyperactive usually happens within 0 to 3 days, not months. We have seen the process of establishment of vascularization, right? It takes 3 to 7 days. When the graft is rejected, given the time response called hyperacute response, you don't need 1 month or 12 months. Within 3 days, the graft will be completely rejected. In acute, it may take 100 days. In chronic, it may be more. We will see that. What are the fundamentally, what cells will help in the rejection? What is the fundamental aspects of those responses? The first response is called hyperacute rejection. It is in normally it doesn't happen. It happens in a very rare instances. And why it happens? Because it will be associated with a specific antibodies called serum antibodies or allo antibodies already present in the body. So let's say a patient X who is planning for a kind of heart transplant is looking for a donor. Sometimes they matched someone, but they couldn't able to identify that the person who needs the heart himself has some antibodies somehow by prior blood transfusion or some other mechanism. He acquired specific antibodies to specific alloantigens, and given the transplant, these alloantibodies encountered previously, they may recognize the alloantigen coming from the graft, and they may elicit immediate response, and they may try to kill the graft as quickly as possible because they have the system in the system, the antibodies are in place, they can clonal propagate and they can recognize the antigens coming from that. So hyperacute rejection, in rare instances, a transplant is rejected so quickly within 3 days that the grafted tissue never becomes vascularized, 3 to 7 days for vascularization. These hyperacute reactions are caused by pre-existing host serum antibodies specific to antigen of the graft. So allo antibodies, as discussed in a previous slide, they recognize allo antigen from the graft. It's not new to them. They have been exposed previously during the life course of the patient. So they can immediately respond within 3 days. So how they do that? Basically, it's a classical antigen antibody complexes. A classical complement system cascade can be elicited. So that brings some other immune cells there and the grafted tissue. So it's nothing but an example of you're showing the graphical representation how are hyperacute in terms of a kidney graft. A patient who received a graft, kidney graft from the other individual, and pre-existing antibodies already in the serum antibodies in the blood. Normal blood goes into the normal kidney, transplanted kidney or the graft. When it goes there, it already sees the alloantigen in the capillary endothelial cell. It also recognizes them, specific antibodies. They go and bind alloantibody, alloantigen reaction. It basically calls specific neutrophils, which can release some lytic enzyme along with the complement cascade, lytic last cascade protein that kills probably the lines. Along with that, they bring some neutrophils, lytic enzymes, some platelets will come. There will be a kind of vascular blockage and tissue damage. Eventually, the kidney will be rejected. So that's a case of hyperacute rejection. So in hyperacute rejection at the molecular level, it is mediated by antibodies. The antibodies are nothing but alloantibodies in terms of alloantigens. So per se, in another case, do you think some other immune cells going to help to grab the rejection? Yes, we have not the B cells or lymphocytes. The part of the lymphocytes are the B cells. We have T cells also. In the T cells, we have T cytotoxic, T helper cells. Each one of them carry their own mechanism. We will see how they will help in another case of graft rejection. For example, acute rejection 10 days after transplantation, it is mediated by T cell responses. Cell-mediated allograft rejection or acute rejection of the graft beginning after 10 days after transplantation. So when you examine the tissue, in the graft tissue where it's been going to die soon, histopathological examination, they show that massive infiltration of macrophages and lymphocytes at the site of tissue destruction, and suggesting that in terms of the lymphocytes, the macrophages are there. Basically, when the macrophage associate, usually it gives an indication of T helper cell activation and proliferation. So in the acute rejection case, this is the mechanism. On the other side, there is a chronic rejection case that is usually takes months or years post-transplant. For example, a person who received the transplant, everything goes smooth, matching is fine, no reaction, nothing, no hypersensitivity or no cross-reactivity. He looks good, he looks well, and he leaves the hospital. But after a few months or certain years later, he faces some issues in terms of the transplantation. So, and then he comes and complains and the physician to take care of it. This rejection usually, as suggested, develops quite late. That's why it's called chronic rejection. And the chronic rejection mainly involves both humoral and cell-mediated responses, saying that humoral means it includes antibodies, cell-mediated, it includes T helper cells and T cytotoxics. So it's a chronic rejection. So how do you revert the rejection, either all transplantation rejection processes? You try to suppress the immune responses. You try to suppress the recipient lymphocytes per se, B and T lymphocytes, using immunosuppressive drugs that will help you to survival of the graft. But whatever the immunosuppressive drugs used by physicians so far in transplantation biology, they have limited success in terms of the time and duration. For the long-term survival of the graft, sometimes this immunosuppression will not work. At certain stage, given months or years, the graft will be again recognized. The immune cells will make them recognize them and then elicit an immune response to kill the graft. Okay? That's the three types: chronic, acute, and then hyperacute. Hyperacute involves alloantibodies, and then acute involves the T helper cells mainly, and then chronic involves both humoral and cell mediated, saying antibodies, and T cells. It involves both of them. Okay, hopefully everything is going fine. You guys are understanding it. Now we go in terms of the mechanistic view, how the B cells will kill, how the T cells will kill the graft. So it's the mechanism is nothing but we already have seen several of that complement cascade, how it works. In terms of the T helper and T cytotoxic cells, we haven't seen what are the downstream partners, molecules elicited by that. The molecules are nothing but cytokines. We will see that what are those. Fundamentally, if you take into the graft rejection, the process can be divided into two stages, the stage 1 and stage 2. It is nothing but primary immune response, secondary immune response. Secondary immune response is effective, very quick, but primary it takes some time. Likewise, the graft rejection process also involves two stages, two steps. The first step is called sensitization phase, in which antigen reactive lymphocytes of the recipient, you're looking in terms of the recipient, they will recognize the alloantigens on the graft and they slowly proliferate, try to recognize, try to make sure that I am sure this antigen is alloantigen coming from the graft, it's a foreign tissue. I will take some time, slowly sensitize myself, given my lymphocytes and my immune system, slowly take some time and recognize this alloantigen. Make sure that after this sensitization process, they are alloantigen, not the self-antigen, and probably coming from a foreign tissue or the graft. Then immediately after sensitization, the immune cells need to go into an effector stage, basically killing the graft, destruction of the graft stage. Sensitization, effector, sensitization, antigen reactive lymphocytes of the recipient try to recognize the alloantigens of the graft. So fundamentally, look into that. You are looking now into all the cells in a summarized slide here. It is coming from Kube Immunology, chapter 21. Look into that. Specifically in terms of stages of effector phase, we are bringing new two terms here that are nothing but interleukins and interferons. These are the other chemical molecules that coming from T cell mediated immunity. Somehow the unit 4 covers it in more details. So I will briefly brush up how they will help in transplant rejection. We will take them in more detail in unit 4. Coming on, so the antigen presenting cell, MHC molecule, T helper cell, a ternary complex will form. This is CD4 molecule. This is fundamentally talking in terms of T helper cell, APC cell. Given a same organism, they will recognize each other like this. But given a different graft, the graft will also have some of these MHC molecules, which are alloantigens. So they may also carry some of the antigen presenting cells. So there is a kind of one more set, self, non-self. So T helper cells can also recognize cells from the graft. Once they recognize that, they will elicit specific kind of interleukin responses. According to these are IL-2, IL-2, IL-2 and IL-4, IL-5 and IL-6. Interleukins are upregulated given the T helper cells, and there is a kind of crosstalk between different B and T lymphocytes, and there is what happens, crosstalk here, we will talk again, go to the previous slide. A crosstalk happens, all the cells will come in place, and then each cell will be given a specific duty, specific biological phenomenon, biochemical phenomenon based on the molecules it carry, and basically the graft is here. Each can go and attack the graft with a specific pathway here. So in a given situation, a T helper cell can recognize a foreign alloantigen through its T cell receptor. An interleukin cascade specifically, and each cascade molecule will have a specific interacting partner in terms of the B lymphocyte, T lymphocyte, and this is nothing but one more T cell that called delayed type hypersensitivity reaction, TDH. We'll see that in the next chapter. So 4 cells are elicited through interleukins, and then what they will do, specifically each cell will have their own mechanism. We will see, and antibodies we have already seen in the previous class. We will just recap that. Giving a scenario of the elicitation of the IL-2, TDH will form. The TDH will produce 2 molecules called interferons gamma and tumor necrosis factor beta. These molecules, again, they will have specific interactive function. This interferon gamma will interact with the activated macrophage, and they produce lytic enzyme, perforin per se. They kill the graft, leaving this pathway itself, one pathway here. On the other pathway, you look in, there are several pathways which can be highlighted here in the purple. Lytic enzyme, MHC expression, cytotoxicity, membrane damage, again lysis, again ADCC. ADCC is nothing but antibody dependent cell mediated cytotoxicity. We will take each and then we will briefly discuss here. So given that TDH, given the interferon gamma, they activate macrophages, lytic enzyme, this one process to kill the graft. Here the host immune system is killing the graft. On the other hand, the INF gamma and TNF beta, they together, they may encourage one more process called increased MHC expression. So because, as we suggested, the B cells should go into a clonal propagation to give multitude of B cells to kill the antigen, right? But let's say the graft tissue, it will bring a limited molecule of alloantigens, because given the volume of the tissue compared to the whole different lymphoid organ tissues of the host, the MHC molecules present on the graft will be in a limited populations. So if you want to kill the graft, you first thing as to you, what are the foreign MHCs? You need to multiply them so that your immune system distinguishes your own MHCs, giving the MHCs of the graft. So to do that, these 2 molecules will increase the MHC expression of the graft specifically. So there is a multiple molecule, millions and millions of MHCs from the graft can be expressed, can be available for the immune system of the host. Then each one of them elicit different response. For example, this green is class 1 MHC alloantigen. It is involved by the T cytotoxic cell, and again this is involved by the T cytotoxic cell, again CD8 positive, CD4 positive. The class 2 MHC alloantigen, they will recognize, and together they will cause a membrane damage. For example, this is mediated by T cytotoxic cells, membrane damage. So MHC expression is increased by TDH cell as increased molecules of INF and tumor necrosis factor. They go and bind the gene in terms of the promoter of these MHCs. They increase the expression of that one part. Again, the tumor necrosis factor beta, it directly induces a cytotoxic response on the graft. It can kill it. Okay, one aspect. So this is mediated by membrane damage. Class 1, class 2 alloantigens recognized by the T cytotoxic cells. These 2 pathways come here. Then if you distinguish further, there is a B cells also. We already know that there is a T cell communicate with B cell, humoral cell mediated crosstalk. And the B cell can induce 2 kind of responses. The one response may be classical antigen antibody recognition. It can induce a complement pathway and it can lyse the graft given the response. Or alternately, it goes through a pathway called antibody dependent cell mediated toxicity. It is also production of cytokines, but the cytotoxicity is mediated by the antibodies, not the T lymphocyte. So basically, it calls an NK cell or a macrophage based on the receptor, FC receptor on the antibody. They recognize the NK cell, and the NK cell comes when they recognize the graft. They induce the ADCC and eventually kill the graft. So the graft immune cells, given the host immune response is dominant, it will have limitations, and in terms of the molecules where it can fight the host, it will have limitations. So limited MHC molecule. So basically the host will take over control of the graft, multitude of the MHC expression, multitude of the different immune responses in the host can come and eventually they divulge and converge into the graft and they will kill the graft eventually. This is a fundamental mechanistic view. Interleukins and interferons, they play a key role in that. We will look further more of this in the unit 4, where cytokines we will talk much more. But fundamentally look in that when the transplant is rejected from the host, these are the mechanism it can involve. We will take a little bit more in the end of the class how the graft can kill the host. If the graft is dominant, how it will kill, we will see that, because the graft is going to kill the host. Basically, we will be looking all these cells, specifically T cells. It will not involve B cells, it will involve T cells only. They will be coming up from here, from the graft. So we will see how it will happen. So far we covered transplant rejection types and the mechanism of transplant rejection. Now we go a little bit more details into graft versus host reaction. What is this disease? Why the graft will dominate over the host? Why it will dominate? Because the host will have a compromised immune system. But we have seen that, but we'll look. The host will have a compromised immune system where it's not working properly. Then the graft can take over and kill the host. So graft versus host disease, the donor bone marrow or stem cells attack the recipient. And it should be remembered that graft versus host disease can occur at any time after transplant. So there is only acute and chronic here. Hyperacute will not happen always, because the graft cannot kill the host immediately, right? The host is maybe weak or strong, but the graft needs some time to attack the host. So basically there is no hyperacute response in GVHD, but there will be acute and chronic responses. That's why it will take some time, and it can kill, occur at any time after transplantation. Usually the phenomena is that it's more common after the marrow has started to make the healthy cells. So fundamentally, if you are transplanting a bone marrow here, for example, the graft should make its own bone marrow, right? Maybe the recipient bone marrow is completely immunodeficient, or they have a disease in terms of the bone marrow. The bone marrow is not making any hematopoietic cells. So basically they need to replace the bone marrow. Then they are grafting the bone marrow from the donor. And when the disease explicitly shows up, it will not show unless the bone marrow from the donor makes its own cells and puts them into the recipient body or cells. Up to that point, no attack happens. That's why there is no hyperacute. So this condition may be mild to severe. We will see what is that. Basically, look into the term. And we will come back about what kind of tissues can be used for graft. GVHD diseases, there are many tissues, specifically 3 classes, 3 elements of the tissues. We will look in further slides. So basically, you're looking in the graft, killing the host. Basically, the graft will be bringing mainly 2 types of cells. One is bone marrow or the peripheral blood cells. We will look into that further. So if you talk in terms of more of immune terms, graft versus host reaction is nothing but it's a severe adverse immunological reaction following allogenic bone marrow transplantation. You are looking for, in terms of GVHD, only the case of bone marrow transplantation and few other case of tissues induced by reaction of donor T cells. You're talking in terms of the donor, the T lymphocytes mainly, they are immunocompetent coming from that bone marrow, and they will immediately immunocompromised or incompetent recipient, they will kill the donor cells in that. So basically, recipient histoincompatible antigens are here. The reaction of donor T cells which are immunocompetent coming from the bone marrow, coming from the graft. So several procedures are in terms of health conditions or health transplantation condition which will have a risk of GVH disease are mainly a few types. For example, allogenic hematopoietic stem cell transplant. So we will see that in an immunosuppressive drugs, what are those? We will see a little bit more on this. But you look in a case of you're transplanting hematopoietic stem cell transplantation. That includes bone marrow transplantation, that may include umbilical cord blood, or it may include peripheral blood stem cell transplantation. So it's in these conditions, the GVH disease might occur quite often, or in some other cases, if you are doing a solid organ transplantation, in terms of the organs containing rich lymphoid tissue. Please highlight this point that you are bringing a live tissue that has a rich lymphoid tissue along with it. So basically you are saying that it is going to bring highly immunocompetent immune cells along with it. One of the cases may be liver transplantation, heart transplantation, and rarely kidney transplantation. So again, three key elements the graft brings. The graft must contain competent immune cells coming from either hematopoietic stem cell transplantation or bone marrow or peripheral blood or umbilical cord. So you will do this kind of transplantation usually to the patients, leukemia patients, where his own system is not making enough white blood cells or red blood cells. So basically they are not properly functioning. So you need a transplant bone marrow to make the blood function normally. So GVHD as suggested, it is again never a case of hyperacute. It will be acute and chronic. The response will be less than 100 days here. Chronic will be less than more days here. And response usually involves immunocompetent T cells from the donor. Incidence in given a population, given a cases, it's only 1 to 2%, but mortality rate is very high. Given the 1 to 2%, 75% cases will die. They will not survive. So this is really very important to control the GVHD disease during transplantation. In terms of pathology, nothing but the host immune system is immunocompromised. The immune cells blue from the host are not functionally active. The donor's immune cells are competent, highly active. So they takes over it. Of the donor cells, mainly what kills the host is nothing but the T cells, which are CD4 and CD8 positive. It mediates a process of T cell mediated response. So a case of grafted tissue bringing its cytotoxic T cells along with it, and then it comes into the foreign territory of the recipient. Basically, it recognizes the MHCs as allo antigens here, and basically it says, I'm not happy with you. I have a stronger immune system now. These T cytotoxic cells will release two molecules called perforins and granzymes. Perforins will perforate the target tissue, forming pores and killing it. Specific molecules called granzymes, they induce a specific response of apoptosis, that's called cell death. Basically, it kills the tissue. When the graft is bringing specifically cytotoxic T cells, we're talking TC cells. How about T helper cells? The graft can also bring T helper cells, right? If that's the case, the graft bring T helper cells, how is it going to recognize the host and how is it going to respond? How is it going to kill? So basically T helper cells we have seen in the mechanistic view in the before, it's nothing but they will bring two molecules, interferons and interleukins, right? Now it's coming from the graft, it's from the donor. So what is that? Specifically the donor T helper cells from the donor can recognize these are dendritic cells in the blue from the recipient. They have MHC molecule class 2 molecules here, and it recognizes them. When it recognizes, it induces two molecules, interleukin 2, interferon gamma. One activates phagocytosis, killing the pro-inflammatory response. Another activates a different response of T cells again. T cells will induce more MHC expression, and then donor and recipient host cell fight each other again. Eventually, these interleukins coming from the donor will kill it. Basically, you should remember one more fundamental aspect here, that the dendritic cells of the host, they will be revolving around the host lymphoid organs, primary and secondary. They will be moving around the host tissues. They will be going everywhere. They will be trying to find the antigens, and they will trying to help the T helper cells of the host. But when the bone marrow transplantation happened, when the bone marrow from the donor produces its own cells, they will go and establish in the recipient also, right? Mainly, they will establish themselves in the lymphoid organs. These cells coming from the donor, they go in, reside in the lymphoid organ, lymph nodes, and then the host dendritic cells will moving around, traveling. When they reach here in the lymph nodes, then these foreign helper cells will recognize them. Then they are highly competent. They may elicit a response such as interleukin, interferons to kill them. So two types of response from the graft. Is a graft bringing T cytotoxic cells, graft bringing T helper cells involving specific interleukins and interferon response. So it's a way happens. It's you're looking in terms of the host, same mechanism, mechanistic view, it will be flipped. And if you look into the donor, it will be flipped back into that. My T cells are active here. So that's a way in terms of the graft versus host disease, in terms of the mechanistic way and fundamentally. And given a scenario of symptoms and diagnosis, how do you recognize GVHD in pathological condition? Basically, any transplantation per se will have symptoms, will have different types of tissues affected. So basically the physicians will look for specific hallmarks of transplantation diseases. For example, mainly 3 tissues are involved: skin, liver, and digestive system. When skin is affected, given again responses are acute, less than 3 months, chronic, more than 3 months or years. If it's less than 3 months, it's nothing but skin rashes, start slowly and it goes whole over the body. You can physically recognize. Liver is usually asymptomatic, but increased levels of the enzymes of the liver, it will give a response. And parts of digestive system will have abdominal pain, diarrhea. It takes some the time. Even more than 3 months, again skin thickening, eye and lacrimal glands burning, digestive system, mouth, lungs will be breath shortness, and muscles will have cramp. This is another way you recognize that. How do you diagnose them? Based on the lab test, imaging studies, you can do biopsies, pathophysiology to see what immune cells are present, which will help you in the assess damage. For treatment's sake, you can go with, in terms of the temporarily, intravenous glucocorticoids. They suppress cell-mediated immune response temporarily, but it should not be given long-term because they may have side effects. Okay. Now I will conclude the class. On Saturday, we will take xenotransplantation and immunosuppression mechanism. Okay, thank you. See you all on Saturday.